Hello, my name is Petra Sierra, and today I will be presenting my Doctor of Nursing Practice project titled Enhancing Outpatient Cardiovascular Prevention, a Clinical Practice Guideline for ASCVD Risk Stratification and Management. The purpose of this work was to address a major gap in outpatient cardiovascular prevention by creating a standardized, evidence-based clinical practice guideline that providers can realistically use in daily practice. I would like to begin by acknowledging the individuals who supported me through this journey. This project was developed in collaboration with my chair, Dr. Wunderlich, along with my academic and community partner, Dr. Snell and Dr. Singh. I am deeply grateful for their support and expertise. Atherosclerotic cardiovascular disease, or ASCVD, continues to be the leading cause of death globally, accounting for more than 18 million deaths every year. It encompasses heart attacks, strokes, and peripheral vascular disease, conditions that are largely preventable with early identification and appropriate intervention. Despite the strength of current national and international evidence, ASCVD prevention in outpatient settings remains highly inconsistent. Outpatient clinics are where early detection should occur, yet this is often where the largest gaps appear. Providers are managing high patient volumes, addressing multiple competing priorities, and may not consistently apply standardized cardiovascular risk assessments during routine visits. One of the major issues highlighted in the literature is the underutilization of validated risk calculators, such as the ASCVD Risk Estimator Plus and the SCORE2 tool. These calculators provide reliable 10-year and lifetime risk estimates. But in real-world outpatient practice, clinicians frequently rely on clinical judgment alone or time-limited assessments rather than evidence-based risk scoring. Additionally, guideline adherence varies widely between clinicians and across practice settings. Factors such as time constraints, EHR limitations, lack of workflow integration, and differences in provider familiarity with current guidelines all contribute to inconsistent care. Because of this, treatment decisions like whether to start a statin or order further testing may become subjective, and patients with similar risk profiles may receive very different levels of preventative care. This inconsistency in practice presents a significant obstacle to reducing ASCVD events. When risk is not assessed accurately or consistently, opportunities for early intervention are missed, and patients often reach advanced disease stages before appropriate treatment is initiated. The purpose of my project was to address these gaps by creating an easy-to-use, evidence-based clinical practice guideline, specifically designed for the outpatient clinic where I completed my practicum. The goal was to combine the best available evidence from the American College of Cardiology, ACC, American Heart Association, AHA, and the European Society of Cardiology, ESC, guidelines into a single, streamlined tool that could be realistically integrated into clinic workflow. My literature review revealed several key themes that directly informed the development of the clinical practice guideline. First, the literature overwhelmingly supports the use of validated ASCVD risk assessment tools. Tools such as the ASCVD Risk Estimator Plus, recommended by the ACC and AHA, and the SCORE2 algorithm, preferred by the ESC, are all shown to significantly enhance the accuracy of cardiovascular risk prediction. These tools incorporate multiple variables: cholesterol levels, blood pressure, age, sex, smoking status, and comorbidities, and consistently outperform clinical judgment alone. Studies demonstrate that when these calculators are used, clinicians identify high-risk patients earlier and initiate preventative therapy more appropriately. Second, all major guideline organizations agree that early and accurate assessment is the cornerstone of ASCVD prevention. There is a shared emphasis on standardized risk stratification to guide treatment intensity. Despite slight differences in thresholds or regional considerations, the message is the same. Consistent risk assessment is essential to prevent heart attacks and strokes. However, the literature also consistently reports that these tools are underutilized in outpatient practice. Multiple studies highlight that providers frequently rely on subjective clinical judgment or quick visual assessment instead of validated calculators. Common reasons include lack of time during short outpatient visits, limited EHR integration, unfamiliarity with these calculators, or workflow barriers that make the tools difficult to access quickly. As a result, many high-risk patients are not formally risk stratified, which leads to missed opportunities for timely intervention. Third, the literature reinforces that statin therapy remains the backbone of ASCVD prevention. Statins have decades of evidence demonstrating reductions in cardiovascular events, yet underprescribing is still common. Even among patients who meet strong guideline indications, many are either not prescribed statins at all or given suboptimal dosages. Research attributes this gap to clinical inertia, uncertainty about guideline criteria, patient misconceptions, and lack of structured decision support tools. Fourth, evidence shows that a growing role for non-statin therapies for patients who cannot tolerate statins or require additional LDL-C lowering. These medications have expanded treatment options, especially for high-risk individuals. Yet, too, they are often underutilized because providers lack a streamlined algorithm for when and how to initiate them. Finally, the literature reveals consistent implementation barriers that prevent guideline adherence, time limitations to busy outpatient settings, inconsistent provider training, lack of ER integration or decision support, variability in individual provider knowledge, patient reluctance or misunderstanding about statin therapy. These barriers collectively contribute to high variability in ASCVD prevention, meaning two patients with identical risk factors may receive very different levels of care depending on the provider that they see. Taken together, the evidence clearly demonstrated the need for standardized, outpatient-focused clinical practice guideline. Such a guideline addresses the key issues identified in the literature, improving risk assessment, consistency, enhancing treatment decision-making, and overcoming workflow barriers. This comprehensive review guided every step of the guideline development process for this project. The theoretical framework that guided this project was the Haynes and Jones translation model, which is centered on closing the gap between evidence and real-world clinical practice. This model is highly applicable to DNP level work because it emphasizes transforming high-quality research into practical, usable tools that clinicians can readily apply to their day-to-day workflow. The model highlights a critical concern in healthcare. Even when strong evidence exists, it is often slow to be integrated into actual practice, sometimes taking years before guideline recommendations are fully adopted. This delay contributes to inconsistent care, preventable complications, and wide variations to patient outcomes. The Haynes and Jones model addresses this by focusing on several core components. One, synthesizing and appraising the evidence. The model begins with a review of current research to ensure that the intervention, whether a guideline, protocol, or tool, is grounded in the best available science. For this project, that meant critically evaluating ASCVD guidance from ACC, AHA, ESC, and additional peer-reviewed studies to ensure the clinical practice guideline reflected current high-quality evidence. Second, developing a practical context-appropriate intervention. The model emphasized that evidence must be adapted to local clinical environment, making it realistic for providers to use within their existing constraints. This was especially important for outpatient care, where limited time and workflows differ from hospital to specialty settings. The guideline was intentionally designed to be concise, accessible, and aligned with how outpatient providers deliver care in a typical 15 to 20-minute visit. Engaging key stakeholders early, the model underscores the importance of involving clinicians and decision makers in the process to increase buy-in and adoption. Following this principle, I worked with outpatient providers, including physicians and a nurse practitioner, to ensure the guideline addressed their needs, preferences, and workflow concerns. Their feedback through the agreed-to appraisal allowed us to strengthen the final product and increase its usability and acceptance. Promoting structured implementation, the model encourages moving beyond simply educating providers. It provides building tools, workflows, and system-level supports that make evidence easy to apply. Although full implementation was outside the scope of this project, the guideline was intentionally created in a format that could be integrated into the electronic health record or used as a decision supporting tool in the future. Taken together, the Haynes and Jones translation model shaped the development and refinement of the ASCVD clinical practice guideline. It ensured that the project did not simply collect and summarize research, but instead translated evidence into a practical tool that providers can use consistently to improve cardiovascular risk assessment and patient outcomes. By grounding the project in this model, the work aligns with the broader purpose of the DMP degree, turning evidence into action and creating sustainable clinical improvements. This was a quality improvement project. The focus was on developing and evaluating a guideline based on existing evidence. The project had three major steps: developing the CPG, using evidence from ACC, AHA, and ESC guidelines, presenting the guideline to outpatient providers, having providers formally evaluate it using the agreed-to instrument. I selected this design because it aligns with the DMP practice outcomes. The goal was to improve processes and standardize care. The sample consisted of 3 outpatient providers from the clinic, 2 physicians, and 1 family nurse practitioner. All had at least 1 year of clinical experience and all regularly cared for patients with cardiovascular risk factors. We had a 100% response rate. All agreed-to tools were returned with full data, allowing for complete analysis. The agreed-to instrument uses a 7-point Likert scale across 23 items divided into 6 domains. Scale domain scores are calculated using a standardized formula, which creates objective percentages for each domain. This allows comparison across domains and clearly identifies strengths and weaknesses in the guideline. The results of the agreed-to appraisal were excellent. Every domain scored above 90%. 3 domains, rigor of development, clarity of presentation, and applicability, received perfect 100% scores. Providers strongly agreed that the guideline was clearly written, easy to follow, and based on rigorous evidence. Editorial independence scored 95%, confirming that the guideline was transparent and free from outside influence. This tells us that the guideline is not only evidence-based, but also practicable, acceptable, and ready for implementation. As you can see in this graph, the scale domain scores demonstrate near perfect agreement across reviewers. The visual presentation shows that clarity, rigor, and applicability were major strengths, indicating strong alignment with national guideline development standards. This table shows the unanimous yes for recommending the guideline for clinical use. Next, we will review some limitations. First, the sample size was small. only 3 outpatient providers participated in the AGREE appraisal. While their feedback was valuable and consistent, a larger sample could have provided broader perspectives and potentially revealed different insights, especially regarding workflow barriers or implementation challenges. Because AGREE 2 is designed to work best with 2 to 4 reviewers, our sample was appropriate, but still limited in terms of diversity and representation. Second, this project was conducted in a single outpatient clinic, which limits the generalizability of the findings. Workflows, staffing patterns, resources, and patient demographics vary widely across outpatient practices. What works well in one clinic may need modification in another, particularly in settings with limited technology, maybe fewer staff, or different patient population needs. Future projects could enhance generalizability by evaluating the guideline across multiple sites. Third, this project did not involve patient-level implementation or outcome measurement because the goal of the project was to develop and evaluate the guideline, not to implement it. We did not measure effects of LDL-C levels, statin initiation rates, patient adherence, or ASCVD event reduction. Therefore, although the AGREE 2 results tell us that the guideline is highly quality and ready for use, we cannot yet determine its clinical impact on patient outcomes. Fourth, the project used a cross-sectional design, meaning the appraisal occurred at a single point in time. We did not follow providers over weeks or months to evaluate sustained use, workflow integration, or long-term adherence. The literature shows that early enthusiasm for new guidelines can decline over time without ongoing support, training, and system integration. Longitudinal assessment would be necessarily to fully evaluate sustainability and actual practice change. Fifth, there may have been some response bias. Even though appraisals were anonymous, providers may have felt inclined to rate the guideline favorably, especially since they worked in the same practice environment where the guideline was developed. Although scores were high, additional external reviewers could strengthen objectivity. Lastly, the outpatient clinic lacked EHR integrated decision support tools, which could influence how easily providers would use the guideline in real-world practice. Without structured reminders, automated calculators, or embedded prompts, implementation may be more challenging than it appears in a paper-based appraisal. Overall, while these limitations do not diminish the significance of the project, they highlight need for future steps such as implementation, multi-site evaluation, EHR integration, and patient-level measurement to fully understand the long-term impact of the clinical practice guideline. The findings of this project demonstrate that the clinical practice guideline developed for ASCVD risk stratification and management is both high quality and clinically meaningful for outpatient practice. The AGREE 2 scores were exceptionally strong, with all 6 domains scoring above 90% and 3 domains, rigor of development, clarity of presentation, and applicability, scoring a perfect 100%. These results indicate that the guideline met or exceeded accepted national standards for evidence-based guideline development. First, the results show that the guideline was viewed as a clear and easy to follow. This is critical in outpatient settings where providers have limited time and need tools that are both straightforward and efficient. The reviewers strongly agree that the guideline clearly defined its purpose, target population, and key recommendations. This clarity increases the likelihood that providers will use the guideline consistently in daily practice. Secondly, the high score in the rigor of development domain reflects the strength of the evidence synthesis. The guideline was built using the most current ACC, AHA, and ESC recommendations, along with supporting literature. This rigorous, structured approach reassures provider that the recommendations are trustworthy, scientifically sound, and aligned with widely accepted cardiovascular prevention standards. For a DMP project, this is especially important because it demonstrates the effective translation of research evidence into practical clinical tools. Thirdly, the perfect score in the applicability domain is particularly meaningful. This domain evaluates whether the guideline can be realistically applied in real-world practice settings. Reviewers agreed that the recommendations were not only evidence-based, but also feasible within the workflow, staffing patterns, and resource availability of the outpatient clinic. This suggests that the guideline is not just academically sound, it is truly usable. Fourth, the strong score in the stakeholder involvement reflects successful engagement of the clinical team. Involving physicians and an advanced practice provider ensured a multidisciplinary perspective and fostered early buy-in. The literature shows that guideline implementation is more successful when stakeholders are engaged from the beginning, and our findings support this principle. Fifth, the high scores reinforce the importance of standardization in ASCVD prevention. The literature consistently demonstrates that cardiovascular risk assessments vary widely among providers, leading to missed prevention opportunities. This guideline has the potential to reduce practice variation, improve the accuracy of risk stratification, and support evidence-based decisions around statin initiation and the use of non-statin therapies. Overall, these findings suggest that the guideline is ready for implementation in the outpatient clinic and has strong potential to improve care quality. If adopted, the guideline can help providers identify risk patients earlier, support consistent use of evidence-based risk calculators, improve alignment with national guidelines, promote standardized statin prescribing practices, facilitate more effective shared decision-making with patients. Although this project did not measure patient outcomes, the strong appraisal results indicate that the guideline provides a robust foundation for future implementation and impact evaluation. In summary, the decision of these findings highlights that this project successfully addressed the problem identified in the background and literature review: the need for a clear, practical, evidence-based tool to improve ASCVD risk assessment in outpatient practice. The guideline was positively received, rigorously evaluated, and strongly supported by the providers who would ultimately use it. This guideline can significantly impact practice. It standardizes how providers assess ASCVD risk and ensures that validated tools are used consistently. It also promotes earlier identification of high-risk patients and supports evidence-based decisions for statin and non-statin therapy. From a nursing perspective, it strengthens the role of nurse practitioners in leading preventative care. It also aligns with value-based care models by reducing variability and improving quality metrics. Ultimately, this guideline helps ensure patients receive consistent, evidence-based cardiovascular prevention. In conclusion, this project successfully developed a high-quality clinical practice guideline for ASCVD risk stratification and management. The guideline was strongly endorsed by providers and achieved excellent agreed-to scores. It has the potential to improve outpatient cardiovascular prevention by standardizing care and supporting evidence-based practice. If I were to continue this work, I would focus on implementing this guideline in the clinic, integrating it into electronic health record, and measuring patient-level outcomes over time. This DMP journey has had a profound impact on me personally. It strengthened my confidence as a leader, deepened my skills in evidence translation, and taught me resilience. It reinforced my commitment to improving patient outcomes through strong evidence-based practice. Here is a list of my references. Thank you for your time and ongoing support.